Hello, everybody, and welcome to this web seminar for professionals. My name is Marcio Garcia dos Santos, and I'm part of BEGO's education and clinical research team, and I will be the moderator of today's session. First of all, I hope that you and your family are all in good health. Before introducing our speaker, I would like to thank Mrs. Angelica Jacob from BEGO's Global Marketing Department for the organization of this session. The topic today will be partial extraction therapy, and the speaker will be Dr. Matko Ogic from Croatia. Dr. Ogic completed his studies at the medical faculty of the University of Rijeka, Croatia in 2014. Even though young by age, Dr. Ogic is an experienced clinician with thousands of successfully osseointegrated implants. He covers the whole range of oral and implant surgery in his line of work, with an emphasis on implant surgery in the aesthetic area. He continually seeks to improve his skills, which is why he pursues ongoing education and deals with the trickiest dental implantology cases. In order to offer the patients the finest care possible, he is committed to using the most recent technologies. He has been acknowledged as a dental expert dentist since 2019. Matko, thanks for accepting the invitation to conduct this session. And please forgive me if Ogic it's correct, or then you can after correct me. As always, at the end of the lecture, what? Sorry?
It is Ogic, but it's okay, it's no problem.
Oh, sorry about that. As always, at the end of the lecture, we will have a question and answer session with the speaker, and you can place your questions in the question box during the whole presentation. I wish us all a very nice time, and then I give the words to Dr. Ogic.
Good evening, everybody. First of all, thank you, Marcio, for the nice introduction, and thank you for the invitation to hold this webinar. In the next 45 minutes, I will explain you the partial extraction therapy philosophy and the biology behind this concept. I will also go through some clinical scenarios and show you some tips and tricks how to implement partial extraction therapy in your daily practice. But before I start with the scientific and the clinical part of presentation, let me first introduce you to the Rindon Dental Clinic, actually clinics, which is where I come from and where all of these cases are being done on a daily basis. So please, Angelica, can you play the first video? Just a second. Do you see the screen, Angelica?
Yes.
Okay, thank you for the video. So it was a short Rindon introduction video. So Rindon is actually two dental clinics that's now 18 years old. We are actually coming of age, and during these 18 years, we have developed in 2 polyclinics, more than 38 dental studios, 3 dental laboratories, and we are working with more than 38 doctors of dental medicine, many dental assistants, dental technicians, and engineers of medical radiology. And even at the beginning, I would like to give credit to all these people because they're making my daily work really a lot easier. So now it would be time to start with the scientific and clinical part of the presentation. We all know that tooth extraction is one of the most performed procedures in dentistry, and the fact that it causes big alterations to the alveolar ridge is well known. According to one of the last systematic reviews on this subject by Van and others, the bone loss is predominantly expressed in the first month after the extraction, and in the first 6 months it can be up to 11 to 22% of bone loss in vertical direction, and 29 to 63% of bone loss in horizontal direction. The bone loss is predominantly expressed on thin buccal bone wall, and according to Chapuis' research, the loss can be up to 7 millimeters of bone loss when the buccal bone wall is thinner than 1 millimeter. 7 millimeters of bone loss is really a huge amount that can give us a really a headache when placing implants. But even though if you're not placing implants, it leaves a big aesthetic impact. Why is that buccal bone walls so problematic? Why is here the biggest resorption of bone after tooth extraction? Well, we all know that the alveolar process is a tooth-dependent structure that develops in conjunction with the eruption of the tooth. A bundle bone is a histologic term this is a portion of this alveolar process that surrounds the tooth and into which the collagen fibers of periodontal ligament are embedded in. Since the crest of the buccal bone is compromised solely of this bundle bone, this is the reason why the biggest resorption after tooth extraction is occurred, especially in this area, because when we extract the tooth, we lose the periodontal ligament, we cut off the bundle bone's blood supply, which causes it to resorb. And these occurrences, as it was described by Araujo and Linda back in 2005, have a direct influence on this delicate buccal bone wall. It has been established that the critical vascular supply to the periodontium and surrounding tissues is a threefold. It means that it's contained of 3 units. We have blood vessels between periosteum and the alveolar bone, within the cancellous portion of the alveolar bone proper, and we have this vascular plexus within the PDL itself. And especially the 3rd unit, it is the vascular plexus within the PDL itself, is the one that differs an implant and a tooth. When we have a tooth, we have vascular plexus, we have PDL, we have vascular plexus within the PDL. When we have an implant, we don't have this vascular plexus. And this is the reason why when we are having a healthy tooth, we have a nice aesthetics of bone and soft tissue. And if an implant is not placed correctly or with some additional augmentation techniques, we always see a ridge deficiency around the implant. On your right picture, you may see scanning electron microscopy of blood vessels in the periodontium, and you may see how many of them there are and how thin they are. And all of them are lost when the tooth is just simply extracted. So this was the reason how the clinicians and scientists started to think, how can we prevent this? In other words, how can we preserve this blood supply? And the logical explanation was the socket shield. If we leave a buccal fragment of the root, we preserve the circulation and we preserve the buccal bundle bone. So we have a portion of the tooth with a healthy periodontium. We still have a blood supply here, and this portion of bundle bone on the crest of the alveolar process will not resorb, and we will have a nice tissue architecture. In the next few slides, I will show you that this wasn't something that was developed just like this by night. It is something that people were doing really a lot of work in order to come to this conclusion. Back like 70 years ago, Thalgreen and then Atwood realized that there are ridge changes and phase changes when people are not having teeth. Their phase starts to change. And first, let's say, partial extraction therapy case was done back in 1972 by Goska when he submerged non-vital roots. In 1975, we have root submergence of first vital roots. And when we are speaking about modern dentistry, we are there is this article of Filippi in 2001 when he submerged roots for a later implant placement. He was treating a young girl. She was in her teenage years, and she was too young to place an implant. So he submerged the root until she came up to the age that she was able to place an implant, and he did it successfully. A more modern period is this article of Salama in 2007, where he did root submergence for implant prosthetics. And then finally 2010, and the famous article of Herzeler, where when the first ever socket shield term arose. In this article on an animal experiment, he concluded that intentionally leaving a buccal fragment with a healthy periodontium and placing an implant doesn't seem to interfere with the osseointegration. Then in 2013, we have first clinical volumetrical histological analysis. In 2013, there is proximal socket shield described for preserving papillae in the aesthetic area. Then there is this Greek group of authors in 2014 that introduced the new name for the socket shield. It's a root membrane technique. It's pretty much the same, just the protocol of doing it is a little bit different. In the next 2 years, well, the biggest criticism during the last 10 years to socket shield was that there is not enough long-term evidence, qualitative papers that can really give to socket shield that what it deserves, that it is a really good application and technology. I mean, a really good procedure to preserve the tissues. And there are many cases that have been published in the last 10 years. I mentioned here just some of them that had the biggest clinical impact. And as I'm primarily a clinician, when I read an article, for me, the most important thing is that it has a clinical impact, so that you can really implement something from this article in your daily practice. One of these articles was published last year also by Dr. Paul about minimizing soft tissue formation. I will also explain it, that technique and what was concluded in this research later during one clinical case. Finally, we come to the classification of socket shield. To the classification of partial extraction therapy, excuse me. So partial extraction therapy is not just socket shield. It's 3 different things. Maybe I can add even 4th one, which is blocker technique, which I will also explain a bit later. So socket shield, the one thing that they all have in common is that we are dealing with a tooth that is untreatable in a classic manner, that needs to be extracted, and we have the intention to preserve the alveolus, I mean to preserve the tissues. If we are talking about socket shield, we are talking about technique where we prepare a shield to protect the alveolus, and we are placing an immediate implant that can be loaded, or it doesn't have to be loaded immediately. This tooth can have apical pathology because we will remove it during the socket shield preparation. Then we have pontic shield, which is pretty much everything is the same as socket shield, but there is no implant. So this tooth can also have an apical pathology. We are planning a ponting site beneath a fixed prosthesis or a cantilever. And third entity is a root submergence, where we just submerge the whole root. What's different here, that this tooth cannot have apical pathology, so we need to have healthy amputated pulp or completed endodontic therapy, and we can plan or removable or fixed prosthodontics. A good indication for root submergence is, as I mentioned once before, a young patient who is planned for immediate implant treatment later. Indications and contraindications. Well, to prepare a socket shield, first of all, we need to have a tooth that is not too loose. So it has to have a tooth mobility less than 2. It has to have an intact buccal bone. So we are dealing with socket type 1. Unfortunately, in these 45 minutes, I don't have enough time to explain all the types of socket, but it means it is a socket with intact buccal bone. Of course, there must be no internal or external resorption of the buccal root part, and we need to have a healthy periodontium, so no pocketing on buccal. If we have a tooth that is too loose, actually a too mobile tooth, that has a resorption of the buccal root part, that is periodontally compromised, it has acute apical inflammation or vertical fractures involving the buccal fragment, then we have to be careful and we have to choose a different technique to preserve the tissues. Finally, we are coming to the part of the presentation where I will choose some clinical scenarios, show you some tips and tricks, and talk about how am I doing this technique and what do I have in mind while doing it. I started to perform socket shields back in 2017, and since then I collected a lot of these cases. I've chosen to show you here some single implant placements, some multiple implant placements, full arch cases, and also one case without implant placement, just for tissue aesthetics. Many other cases you may see if you want also on this Instagram account of mine. So Angelica, would you please be so kind now to play the second video, which is just a second. It is actually one of my first socket shield cases. It was done back in 2017. you will see also follow-up from 2008, almost 4 years after, with really healthy and stable tissue. So Angelica, please play the second video. Okay, thank you, Angelica. So for this case, I would like to give credit for doing the prosthodontic part to Dr. Gordana Smiljan, who did all the prosto treatment of this patient. So to get back to this case, as you may have seen during the video, the picture that I used for the cover photo of this presentation was exactly from this video, which is why I really like this case. As I mentioned you already, it was done back in 2017. And this was a patient who wanted to treat his frontal region because he had problems with his central and lateral incisors. After thorough clinical and radiological analysis, we decided that we can do we can place implants on lateral incisors and do a fixed bridge. We decided to go with partial extraction therapy wherever possible, and we prepared socket shields on lateral incisor where we placed the implants, and we preserved the first right central incisor with the root submergence technique. Unfortunately, it wasn't possible to preserve the left central incisor, because you also saw on the picture and on the radiological analysis, it was just impossible due to its pathology. This is actually one of my favorite pictures from this case. I will also tell you later why. It was shared by one famous doctor also, and it was used also as a cover photo for this partial extraction therapy group on Facebook. And there was a good question that this doctor asked: which side has the highest risk of resorption and without doing any further treatments? And the answer is quite obvious. You will see it also afterwards, the answer during the clinical phase. So we are talking about socket shields, and how do I prepare a socket shield? Well, there are many tips and tricks in socket shield preparation, and many different clinicians do it differently. I personally do it just with a simple Lindemann burr and a rounded burr to prepare the coronal portion. Regarding the tips and tricks, there are many articles that are being published that are explaining you how to do it. But if you scan, for instance, this QR code, you will find a really great application called Decision Matters. That is an application for implant dentistry developed by Dr. Snezana Paul, where you can really find some nice, useful tips and tricks, user-friendly tips and tricks, really simply explained how to do something, not just in partial extraction therapy, but also in many other cases. So back to tips and tricks. Well, thickness. It is recommended to have a 1.5 millimeter thick socket shield. Of course, it can be a bit thinner, it can be a bit thicker, but this is what is recommended. And you can go either thinner or thicker. The length can also be variable. So it is recommended to have a 2/3 of the root length. Sometimes it can be shorter, but the most important thing is that it needs to be stable, fixed. It must not be loose. The one thing you cannot alter, that you must really follow, is that you really have to remove all the apex and the root canal content. Regarding the level of socket shield, well, the original article by Herzeler recommended to have 1.5 millimeter higher socket shield than the buccal bone. But during the years, it was shown that it may cause some problems, some complications, not due to implant and socket shield, but due to prosthodontic part of the implant therapy, because if it's too high, implant abutment or crown can push it during the loading phase, and it can you can have complications such as internal or external shield exposure, or even it can become so loose that you will have an implant failure. So now it is recommended to reduce the socket shield to the buccal bone level, because you will have a less risk of shield exposure. And to prepare this, I don't draw really nice, but I try to do it like a small animation here. I mean to show you how it is important to prepare this beveled chamfer here in order to provide more space for soft tissue in this transgingival portion of implant abutment connection. If you decide to leave it 1.5 millimeter higher, then you may have to do some precautions. You have to really thin it in this coronal portion. You have to choose a narrow implant diameter. You have to maintain a gap that I will talk a little about later, and you need to have a sufficient abutment collar height not to push the socket, so not to avoid any complications. The other thing that is quite important, that is maybe not so often mentioned as it should be, is that it is important not to polish this internal part, because fibroblasts are the ones who like polished surfaces. Osteoblasts are not. So you have to leave this internal part as it is, quite rough, in order not to attract fibroblast and soft tissue invagination in this area. I just mentioned you socket shield to implant contact. Well, for instance, in this case, we have both scenarios. I have a socket shield that is in direct contact with the implant, and I have on a lateral incisor a gap between an implant and the socket shield. That was done back in 2017. Back then, I didn't maybe think enough of it, but now when I'm placing an implant and preparing a socket shield, I always plan to have a bit of space. But sometimes the alveolus is so narrow that you just cannot avoid this contact. I mean, you can thin it, but if you go to thin this shield too much, then you can break it. It will become loose or something like that. So sometimes you will just have this contact. But research has shown that there is still no consensus on grafting the gap or not grafting the gap, or to have a gap or not to have it. So there is no clear protocol how to do it, but there are some recommendations. So recommendations say that it is good to have a gap, and there is one also logical explanation to this, because if you are preparing a socket shield and you are placing an implant, it is logical that your implant has to have decent stability in order to place it in a post-extractional manner, especially if you're placing it in order to load it immediately. Then, of course, the torque of the implant has to be quite high in order to bear the load afterwards. If the implant is in the contact with the socket and the torque of the implant insertion is high, during the implant placement, the socket shield can be displaced during the implant placement if the torque of the implant is too high. So this is one logical explanation you need to have in mind when preparing the socket shield and placing an immediate post-extractional implant, to not to throw away maybe sometimes 5 to 10 minutes of socket shield preparation and sometimes 30 minutes of socket shield preparation, because sometimes it really can take a lot of time to prepare it properly. Regarding the filling material, well, it is as for conventional implant, conventional immediate implants. If the gap is more than 1 millimeter wide, then it is recommended to graft the material. And this systematic review was described that it has not been determined which is the best material to use. I will later, I will now actually tell you the best material to use for this gap filling is either autologous dentin if it's possible, or if it's not possible, then it's the best thing to fill it is a autologous bone but obtained from tuberosity, which was, I will later once again explain, realized in one research of Dr. Paul. Okay, this was the delivery day. Here you may see a bit inflamed gingiva because the patient that day of the delivery of the prosthesis came with provisional that were a bit loose. And this is almost 4 years after, because this was beginning of 2017, this was end of 2020. So we have stable tissues, good healthy gingiva with no recessions, and it is loaded for this 3.5 or maybe 4 years without any problems. And as I mentioned during the beginning of this case, Marisa Albert-Salama was a doctor who reposted this picture from the beginning with this really good question: which side has the highest risk for resorption and without any further treatments? And I think the reason, if you even don't see after follow-up picture of anything, the reason is the answer is quite logical. It is this, as he called it, empty container. You may see here how, even though I did a lot of soft and bone tissue augmentation here in order to preserve the architecture of tissues, it is the partial extraction therapy so superior to any other technique in this area that just how it's not doesn't matter how hard you try. In almost 99% of cases, partial extraction therapy will win against the others technique in preserving the tissue architecture. Okay, so I mentioned to you this article that was published in 2001 in the International Journal of Oral and Maxillofacial Implants by Dr. Snezhana Paul. It was there is one technique of partial extraction therapy that is called Glocker technique. What is it? It was described by the same author, Glocker, back in 2014. It is nothing else but a socket shield with delayed implant placement. Sometimes you have really long root of the tooth that has to be extracted, or you see the CT scan and you realize this bone is so soft, my implant will not get a primarily stability. So you can do a delayed implant placement and socket shield, and that's what Glocker technique is. So at the time of extraction, you prepare a socket shield, and then you have an empty alveolus that you can fill with something. You can leave it empty. Back then, we didn't know what to do with this alveolus, so we tried different materials. And Dr. Paul did a research where she placed different materials, and she came to the conclusion that the problem with this thing was this soft tissue invagination. So the gap between the socket shield and the remaining of the alveolus had sometimes this invagination of soft tissue, and sometimes this soft tissue invagination was so big that it fulfilled the whole alveolus. And she realized that when she was using autologous dentin to fill the alveolus, or when she was using bone from tuberosity, that it was so minimal, the soft tissue invagination, that was clinically irrelevant. And based on the conclusions of this paper, I did a similar case here. It was a case which for the prosthodontical part, I have to give credits to Dr. Daniela Grgic-Miljanic, who recognized the good intention for socket shield here. And we, but since the bone was really soft in this patient, I decided not to go with immediate implant placement because I already knew that the implant wouldn't get enough primary stability to leave it. So I decided to prepare a socket, and then I covered the alveolus with this piece of tissue, let's call it like that. It is actually 4 different types of tissue in one. It is spongious bone, it is cortical bone from tuberosity, it is keratinized tissue, a gingiva here, and this is a connective tissue, all from tuberosity. The idea of this piece of tissue came from the IDR technique of Dr. Martins da Rosa, which is the idea came from that technique of Dr. da Rosa. So we extracted the tooth, we prepared actually a socket shield, we filled everything with this piece of tissue, and then we let it heal for a few months. After 3 or 4 months, patient came back, and this was what I got on the follow-up. This was whole bone, and this was maybe 1 millimeter of soft tissue invagination. I didn't take a picture with the PeriPro, but it was really clinically irrelevant because when I placed an implant, it was completely surrounded by native healthy autologous bone, and this gap I really didn't care about. I don't even remember if I filled it with something or not. I placed an secondary screw just for some more tissue formation up on occlusal part, and patient received back his fixed prosthesis because I didn't want to make any risk with the loading of this implant since he already have a fixed provisionals. This is how the tissue looked like, this tissue architecture looked like after 4 months of period. No, this is after the tooth extraction, after 4 months at the time of implant placement. This is from this view, and this is how the CT scan looked like. So we see a healthy bone, and we see a socket shield here that is protecting our bundle bone that I mentioned you at the beginning. And this is the delivery of the final crown. From this view, we have a really nice maintained architecture of soft tissue, and this is the frontal view with the radiological small radiological image. Okay, so when we are talking about partial extraction therapy, we are not always talking about implants. Sometimes we can do the partial extraction therapy cases without placing implants, just in order to preserve the tissues. This is also a nice case without implant placement, which I've done with Dr. Magdalena Miletić-Matešić, where we had a quite young patient that just wanted to restore her incisors. There was a lot of work here to be done, but she wanted something quick, and she wanted fixed, and she wanted quick, as like more than 90% of patients. We then realized that we recommended even orthodontics and other things, but she didn't want any of it. And then we realized that we had to extract the right central incisor, which was actually a healthy tooth, but it was just too out of the root, out of the arch. And we had to extract the left central incisor because it was that tooth that just had to be extracted. I knew that if I just simply extract these 2 teeth and leave it just like that, we will have a collapse of tissues and aesthetic disaster. So what I decided to do here is a combination of partial extraction therapy. So I submerged the root that was vital. You may see even the pulp here. And when I'm dealing with root submergence therapy with vital roots, you have to cover it with something. I cover it either with pedicle connective tissue graft or with PRF membranes. Here in this case, I covered with pedicle connective tissue graft in PICOS modifications. This can be also cut it off and done differently. And as for the left central incisor, I used pretty much the same technique as described in the previous case, which is the idea that came from Dr. da Rosa. So this, we call it quadriplex graft because it has 4 types of tissues: spongious bone, cortical bone, keratinized tissue, and this is just a connective tissue, all obtained with a chisel and a hammer. It's not really nice for the patient, but I mean, he doesn't feel any pain, but you know, when you have to hammer, then they're not so happy. But it gives results, and this is how the tissues look like after 6 to 8 weeks of healing. There were some recessions to be done, etc., but the patient didn't want any of it. She just wanted to go to definitive restoration. Finally, we come to the last case, which is a full arch guided PET case that I have to give credit for doing a great job in prosthodontics to Dr. Aida Pasic Carrera. This was a case where we really discussed a lot how should we proceed. You will see why on the next slide. And here in the original presentation, in the behind there was a song from the Clash playing "Should I Stay or Should I Go?" But we decided during the test phase of this webinar to remove it because the sound wasn't very good because of these internet connections. We discussed a lot which teeth are to be extracted, which are not to be extracted. Some of them are mobile, some of them are not. But patient wanted definitive restoration. I mean, she didn't want anything temporary, like for a few years and then do something else. So we decided to go with a staged procedure. A staged procedure, it means at the beginning leave some teeth that we will prepare to hold the provisionals. And at the time of the implant uncovery procedures, we will extract the teeth and then do the provisionals on the implants, which is really a great approach, especially if you don't know if you will have to do any bone or hard or soft tissue augmentation. And when you are doing implants with stage procedure, you always have something fixed underneath your augmentation area, under the augmented area, and there is no risk of pressure of any removable prosthesis. And of course, for the patients, it's totally different thing to have something fixed for the provisional rather than a removable prosthesis. So what did we do here? We opted for a fixed bridge on 6 implants. In lateral regions, we had to do sinus lift procedures, but since we were really discussing a lot what should we extract and what we shouldn't, we decided to be to protect as many as possible. So we prepared sockets wherever it was possible, or root submergence technique wherever it was possible. And you will see how this thing was done. What is particular in this case is that the case was done by means of guided surgery. This case was started in 2019. It was finished this spring due to COVID and due to inability of patient to come during the 2 years of COVID. And in 2018, I started doing a lot of these conventional surgical guides for implant placement, and I started thinking, why shouldn't I prepare a guide for a socket shield? This is what I did here. Back then, there was no, I don't even know if now there are some protocols and or video tutorials or anything in order to teach you how to prepare a surgical guide for a socket shield. But I was thinking, okay, I will choose the narrowest implant diameter possible. I will point it towards the apex, and I will choose a small sleeve that is the diameter of the sleeve is pretty much the same as the diameter of my Lindemann burr that I'm using for socket shield preparation. So then, of course, I prepared the other surgical guide for implant placement. And this is how the surgery looked like. First, I placed the guide for socket shield preparation, and this is the small sleeve through to who this Lindemann burr is passing towards the apical area. Whenever I'm preparing sockets, I always put my finger on the apical part, and I'm waiting when you start to feel vibrations when you're in this area of the apex. It means that you are going in a good direction. You may see here on this picture how the palatal, I mean, this is 2/3 of the root length, socket prepared. It was really easy. I was thinking it will be quite hard to prepare it, but in the end, it was maybe, I don't know, around 10 minutes of work. And this is how the socket was then afterwards prepared in this coronal area with a rounded burr. After the socket shield was prepared, I proceeded with the other surgical guide for implant placement. So these are 2 placed implants in the frontal area, and we submerged the central incisors in order to preserve as much tissue as possible. And this area was augmented by means of guided bone regeneration, and then afterwards some soft tissue augmentation. Everything was primarily closed. As I mentioned to you before, patient wore fixed provisionals on canines. And this is the time of implant uncovery. In the meantime, the lateral region was done by means of sinus lift procedures, implant placement, etc., but this is not point of interest at this time. At the implant uncovery procedure, this is how the tissues looked like. So we have, you see that the primary screw was a bit damaged by rounded burr because I had to remove a bit of bone that was above it. And you can see small pieces of bone on these submerged roots. This is our socket with an implant and a really narrow alveolus, and we have again implant in contact with the socket shield. And in lateral regions, since we didn't have an opportunity to do socket shields, I did this. If you scan this QR code, you will find this great article also by Dr. Paul about buccal sliding palatal flap, which is a really good and useful technique. Not just for, it can be used also for hard tissue augmentation, but this was done for soft tissue augmentation of the lateral area in order to have a nice volume of tissue in the lateral area. This is after few weeks of healing. You can still see that the sutures are not resorbed. The wound is still fresh. And here we prepared, this was the time when patient finally received her provisionals. She had few sets of provisionals, first on the tooth, and then she had the first provisional on the implants, and then the last set of provisional on the implants. And here is when we decided to do root submergence technique on the remaining teeth, so canines and the first premolar. So the root submergence, and this is the last set of provisionals, because I don't have so much time to go through all the aspects of this case. This was the last set of provisionals that she received on her implants. This is how it radiologically looks like. So we have 1, 2, 3, 4, 5 submerged root and 1 socket on left lateral incisor. Here was some sinus lift procedures that were done. And this is how the tissues look like just before the final impression. So here we have 2 submerged roots. Here we have 2 submerged roots. Here is a socket shield. Here is a submerged root. And here we did a lot of this soft tissue augmentation, which came out quite successfully. But this picture again shows how the superiority of partial extraction therapy with any other kind of tissue augmentation, because here was just a root that has been cut off and left there, and here we had to cut up the palate, etc., etc., etc. Then we have discomfort of the patient and everything to gain not so good result as here, where the tissue architecture is way thicker than in lateral regions. Finally, okay, once again the radiological image. Here you see the socket shield and the implant. And this is the beginning and the final restoration, which in the end came up as a FP1 case. Even though the easiest thing here was, we could have cut off a lot of bone, place all on 5, 6 something, and have a lot of pink ceramics. But we didn't want to do this. We wanted to preserve as much as possible. And as once Paolo Carvalho said, which is one of my favorite dentists, that because not all full mouth implant rehabilitations have to end up like a denture. So it is always good to preserve as much as possible, especially when a patient has a normal to high smile line, and especially if we are treating a patient that is not, I don't know, 80 years old. So we are treating when we are treating a younger patients. Okay, finally we are coming slowly to the end. I don't know why this video is not playing. So here is the literature that I've used for preparation of this presentation. And once again, I mentioned you this aesthetic implant dentistry application called Decision Matters. It's a mobile application that if you scan this link, this QR code, it will lead you directly to the website of it, where you can really find some user-friendly tips and tricks how to make your daily practice a lot easier. In the end, I would like to say once again thank you to all the people I work with, to my assistant Nevenka, who always knows what instrument to prepare, to my great guys from surgery department, and to many technicians, Redental Lab, and to many other doctors, without whom all of these cases wouldn't be possible. And for the last slide, I would like to give an extra credit to Maja Lukic, who is our chief of assistants at the surgical department, who is also responsible for many of the pictures you may have seen during this lecture. And her work you can find also on Toothshot Instagram account. She's really accepted. She's exceptional assistant. She's a great photographer. So thank you, Maja, for the pictures. The rest of my cases, if you'd like, you can see on my Instagram account. Of course, you can follow us on Instagram for any info from Rident clinics. So that was pretty much all. I hope that I was in time and that you learned something new. So Marcio, I think I'm now giving word back to you.
Well, what I can say, Matko, thanks a lot. It was really a pleasure to see you speaking. The presentation was really very didactic and with a very nice clinical approach, as you just mentioned. Fantastic didactic material, fantastic photos. Congratulations. Not only the clinical approach, but also, of course, you showed us the scientific based about this very nice technique, showing also the tips and tricks. I myself, I heard the first time in 2011 about the technique, and we are now in 2022, and we are still discussing it as a wow. Does this technique works? Is it good? So you really showed with scientific basis. So thanks a lot for accepting the invitation for the nice presentation. We are open for questions. We have two so far. So first question that came is, in average, how many follow-up years do you already have with different, we know there are different, as you showed us, different partial extraction therapy, but in average, how many follow-up years do you have yourself in the Rident clinic? So yeah.
So the first case I did was in 2017. It was a few months before the one I showed you in this video. It was beginning of 2017. This is a case I didn't show. I have a follow-up of this case. Maybe she came back in 2019, and I didn't see afterwards this patient. Everything was functioning pretty well. And this is actually around 4 years is my longest follow-up period because I think that in the next period the patients will come, because now they usually come when they have problems. When they don't have problems, they just like come every few, like not so often, I mean. But this patient, for instance, one of the longest follow-up is from the case I've shown you, and the cover photo you have seen also. It is around 4 years now.
Perfect. Yeah, and the classic no news, good news. And sometimes if the patient, they do not come, yeah, they should, but sometimes they do not come. And no news, good news. And yeah, we had also the time of the pandemics and things like this that also influenced it. Another question that came, what could be, of course, we know that with planning, it's a very predictable technique, but what could be the most common complications related to different partial extraction therapies technique?
Well, the most common complications are this internal or external shield exposure. Of course, you may have implant failure, and everyone who is working it has it. I even do have complications such as implant failures with socket shield, but not so often that it comes to my mind, wait, am I doing something wrong, or this technique is not good? It's not anything more often than usual implant placement. But this is the thing you can encounter at the implant uncovery procedure or something like that. And during the loading phase, the complication can be internal or external shield exposure, which can usually be treated quite easily. It's not so hard to solve the complication.
And in average, also a question that came in average, how, yeah, is it almost every time possible? Just trying to get the question here the way it was put it. It's almost always possible to place an immediate provisional when we do a partial extraction therapy. So how is the percentage, you would say, more or less, in terms of doing a provisional or a two-stage procedure?
Yeah, well, sometimes I would even say it's not 50-50, but it depends of the type of the socket. It is, I think I mentioned during the lecture, there are different types of socket regarding how the tooth is anatomically placed in the socket. So, and it is one thing it depends. The other thing it depends is the are we dealing with a soft bone, hard bone type of the bone, right? So I would say that not maybe 50-50. There are more cases going in favor to immediately placing and loading implant possibility, but there are quite a lot of cases when I don't get enough primary stability in order to load the implant immediately. Then I proceed with either secondary screw, or I place an individual healing abutment or something like that. But I quite often encounter these cases when it's not possible to load the implant immediately at the time of implant placement and the preparation of socket chip.
Perfect. Just what's your magic number in terms of primary stability?
Magic number as torque?
Yes.
Well, it depends if we are dealing about single implant, if we are dealing about premolar central incisor, if we are dealing a full arch implant case, but around, I would say 45 newtons, maybe 50. If it's a single implant, then I like to have a really good torque. If we are talking about full arch case, 40 is okay for me. I mean, I have good results here.
Perfect. Thank you, Mary, very much. So far, that was the questions. We received already some positive feedbacks from the colleagues. I would also go. I am with them. So thanks very much. Really, the positive feedback approach. I believe no more questions are coming. So if not, once again, Matko, I would like to, in the name of BEGO, the BEGO company, thank you very much for the very nice presentation. Thank you all for being here with us tonight, and we hope to see you in our last web seminar of 2022 in November, and I wish you all a great evening. Just came from the queen of the partial extraction therapy, Sinejana, giving you a great lecture. Nice to have you with us here tonight, Sinejana. Also greetings to you, and yeah, wish you all a very nice evening.
I have to say that Dr. Paul is my clinical mentor, and then a lot of these things I learned from her. So thanks once again.
Yeah, she's really what I would say the top of the technique. You mentioned also the decision matters app from her, which is huge work from her. Very nice. So yeah, thanks for having her here with us tonight. Thank you, Matko, once again, and thank you all. Wish you all a good evening.
Good evening, everybody, and thanks for the attending. Bye bye.
Bye.